This is a video of acute retrocecal appendix. I'm doing laparoscopic appendicectomy. So why retrocecal is special? Once you put a scope inside the abdomen, you cannot able to see the appendix. Everything will be normal, and clinically patients, if you have deep palpation, it's behind the cecum. So if his entire cecum is compressed, then only your pressure will reach the appendix. So it's imaging wise, it will be well seen with the ultrasound and CT, and clinically the patient will have more pain on little on the flank region, and then deep tenderness will be there. So this is a suprapubic view now, and actually this case is started by my colleague, junior colleague. So he is searching for the appendix. So usually I don't hold the cecum or colon with any of the instrument, because that is not our aim. We are, even if you can hold with the small bowel, no problem. If you see my videos, I will not hold the cecum. So always try to not hold the cecum. If you want to hold the cecum, you can hold it at the tinea level. That is a little bit strongest. So there is a developmental adhesions on lateral wall on the terminal ileum, and he couldn't see the appendix. Since it is a ileocecal junction is seen, he made a right side right LFO support for left hand working, and he started with division of the. This is the developmental adhesion. You can see suprapubic port and umbilical 7 mm, right iliac fossa 7 mm, 5 mm, and camera is 5 mm. So 2 5 mm, 1 7 mm port. So that is a good thing. He started with release of the developmental adhesions, and he is using scissor. Always scissor is preferable near the bowel. No need for any energy device. It's very small vessels. It may bleed, automatically it stop. Or you can do very judicial amount of electrocautery. So this will this may give some exposure on the base of the cecum, so we get able to find out the appendix. In this case, clinically appendicitis scan shows edematous appendix, but they are not telling the position. They are not telling the position, and it can be identifiable in ultrasound or CT, but this case they did, the radiologist is not mentioning about the position. He called me after starting the appendix, and I was in different surgery. He called me. He couldn't able to see. He said there is a paracolic area. There is no appendix seen, and retrocecal also could not be seen. So that is the retrocecal area. That is also appendix is not seen. Pelvic position is also not there. So it must be retroileal. So he is mobilizing the ileum. So he is mobilizing the ileum, and that there also he couldn't feel any thickness. So ileum, that retroileal means that area will be thick. So he trying to separate the ileum, but this is not an ideal way. Actually, you have to hold the ileum, and then you have to do short dissection, not the holding the cecum. So usually we have to hold the ileum, and then you can mobilize. So now it's he's holding the ileum, so that is better. And always this is not a place for a suction dissection. Only the inflamed infection, inflamed adhesions, we have to use the suction, not on the developmental adhesion site. So in this case, there is no subcecal, no retroileal, no pelvic, no paracolic. Though that means it should be on the retrocecal only. So you can see it is going, cecum is bending down. It's very clearly seen. So that is the area cecum is bending seen, but it looked like by touching the suction, it is not a thick walled. So that means there is not appendix. So he started mobilizing the cecum by division of the lateral wall of the cecum, but that is not an ideal place to start the mobilization of cecum. So you can see it's very close to the wall, cecal wall. He is working, but that is not ideal place. Always don't try to mobilize the cecum laterally. Laterally, try to mobilize inferiorly, and then go behind the cecum. So posterior mobilization of the cecum is the ideal always. Now you can see I started, and you can see my left hand is always ready Carlson forceps. I don't use a bowel grasper most of the time, and so now I hold the ileum. Now you can see I open the peritoneum, and I am you can say pushing up the ileum. It's very easy. Once the peritoneum is open, you can see dissection is very less, even that fat bleeding to be coagulated. So I'm coming up to the root of mesentery, my left hand is lifting the ilium, and with the harmonic I am pushing down the retroperitoneal structure. You can see so easy, and it will take only 10 minutes time to mobilize the ilium or a cecum. This is what we do in a right hemicolectomy, and it is called IRETA, initial retrocolic tunneling dissection, to mobilize the cecum and ascending. Now you can see the base of cecum is seen cleanly, and the tinea coli is seen, that is the ilium. So it is an unedited surgery. You can see after I took over the surgery is unedited. You can see that is the appendix. So that is the appendix. If not able to hold the appendix with the radiculation, then I will change to uh, bowel grasper. So you can see it is very much inflamed, and it is going down, going down. See, now I am holding the appendix. I am pushing down all the structure. It look like it is coiled. That is the tip I can able to see. So this is the retrocecal appendix. Don't mobilize the cecum laterally, bring the cecum medially and then trying to see the appendix. You have to, this is why clearly mentioned the position is called retrocecal, behind the cecum, behind the cecum. So you have to mobilize the cecum from the down, from inferior surface, open the peritoneum and then lift the cecum up, and then you can able to see the ileocecal junction clearly, and then you can go up to the ascending colon, even up to hepatic flexor you can go in this, in that plane. Now you can see this is the appendix. I highlighted it, it is a coiled appendix. So now you can see I change my instrument, I hold the appendix, you can see that is also atraumatic bowel grasper. So I'm separating the from its posterior attachment. So it's acute, it must be very much painful for the patient. It is not able to distend much because of this coiling. See, now I'm trying to separate the adhesions. I'm trying to separate the adhesions. I'm trying to straighten the appendix. It's not adhesions, basically straighten the appendix between the two bent surface. This is also I'm getting maybe I can say around 6 months or 1 year in a day. I could see one retrocecal appendix in my practice, because appendix I'm not doing regularly. My colleague and junior colleague and my our resident is doing this case, so it is a third level, I can say third or fourth common presentation of appendix. So now I'm taking again posteriorly, and the entire part of ascending colon is also mobilized. So now if I pull means it is coming out. So it was actually facing on the retroperitoneal side, and now it is coming up. So now I have to, here this job is easier, entire appendix is in my hand now. So I have to do dissection, divide the mesoappendix. So now I started dividing the mesoappendix. I try to mobilize the structure, but it is not able to separate. See, now again I am separating the retroperitoneal plane. I am separating, push the plane down, tissue down, so that the entire appendix is in my view. You can see now that lateral side also reached. So it's posteriorly and laterally it is mobilized, cecum and the part of ascending colon. So now I am dividing the mesoappendix. I am going to divide the mesoappendix. See, I am dividing the mesoappendix. So once you divide the mesoappendix, we have a plane. We can see the other side. So I can go close to the appendix so that I can straighten the appendix. Then I can identify the base. No need for retrocecal appendix in this kind of thing. So now I am going close to the appendix, and meso appendix also not to be excised, is not recommended unless if you feel it is a thick edematous and part of gangrenous is there, then you excise. So this is the lateral attachment. I am dividing it. That area is close to the cecum. See, appendix is coiling, turning, and then adherent to the cecum. So that is the tip. So I am starting again division of mesoappendix close to the appendix. So our aim is to mobilize the appendix without cecal injury. That's why the cecal posterior attachment is there. If you pull it with the appendix, then posterior also attached. You are also pulling in one direction. So it chance of tear of cecum is there. So that's why I released posteriorly. So if I pull the appendix, so it will not tear. I can go. I will get some space between the appendix and the cecal wall, and that's what I'm finding out the space, and then I'm dividing the mesoappendix close to the appendix. As much as possible, try to go close to the appendix. And I demonstrated one of this Amasican, and the entire appendix is adherent. Treated case outside is treated conservatively. The entire appendix on the cecal wall, and after the surgery, the moderator comment was, it is very nicely done. Otherwise, you will injure the cecal wall. So that's what happened in some cases. So you have to do very carefully. You have to recognize the position of appendix. That's why I put video of each position. So if you retrocecal, definitely part of the cecum will be on the adherent to the cecal wall, and some cases of subcecal appendix with the coiled rolled appendix, again cecal adhesions will be there. Now you can see this is the portion I dissected, so that is the cecum. So now you can see able to very well, that is the cecal wall and the appendix very clearly seen. You can do sharp dissection with the scissor. You can go close to the appendix, or you can see how much I pull the appendix. You can see the cecum is touching near the abdominal wall. That much I mobilized posteriorly, so that the injury to the cecal wall is unlikely. Otherwise, if it's posterior not mobilized, it will open up. So I am dissecting with my harmonics blade, and then I am dividing it, because I know that some portion of mesoappendix is there. So I will not, injury to the cecum is not possible this by dividing the mesoappendix like this. See, now the appendix is completely. Now immediately you have to check out the dissected area. Don't think that you are not doing any mistake. Always we take a gauze piece or wash that area, and then pull the appendix, and then check that area, any cecal injury or serosal tear you made it. So now you can see I am checking it out. See, camera to go close, cecal wall, see posteriorly. So it is no injury is there. So okay. So now I am started skeletonizing the base of the appendix. Hereafter it is like a normal. So you can appreciate the thick walled appendix treated outside with the antibiotic. And always try to go to the base. Don't leave some part of the appendix. Always take this kind of fascia first. So that will, now you can see that is the base. I could able to see the tinea coli. In some cases, we can see all three tinea coli merging in a retrocecal. So that is the coli. No, retrocecal, we mobilize the cecum, and then you can able to see all three tinea coli. So now it's very clear we are not injured the base of the cecum, ileum. We mobilize the ileocecal junction and the ascending cecum and the ascending colon. And after mobilization, we could able to find out the inflamed appendix. It's a rolled inflamed appendix, and we mobilize the appendix. We divide the mesoappendix, and then now we are ligating the appendix with the catgut endo loop. Already one at the base is applied, and this is the another one around 2-3 mm distance, and now I am dividing appendix. So these are all the regular standard procedure you can see in a regular way. So I convert the 7 mm into 10 millimeter trocar. I'm taking out the, because this will not come through 10 mm, 7 mm. So I convert to 10 mm, and the exposed part of the mucosa of the appendix is sterilized. So now it is very clear. So posteriorly, cecum is mobilized, no injury. So without mobilization of cecum, you cannot do this surgery. Even if you rotate the cecum, if you mobilize laterally and then rotate also, you will not get a good exposure. And now you can see how much exposure we will get from suprapubic port. So this is a really advantage of suprapubic port by for a retrocecal appendix. Thank you so much.